All right, good morning. I just wanted to start out by saying thank you to Dr. Smith, Dr. Yan, and Susan Crutchfield for putting, and anybody else involved in putting this together. So today I'm going to be talking about liver-directed therapy. This is a very large topic, so I could talk about this for hours, and so I will. No, I'm just 30 minutes. So I have no disclosures, and this is an outline of what I'm going to be talking about, ranging from ablation to transarterial and transvenous therapies, and some future directions. So starting with percutaneous ablation, RFA since the early 90s has rapidly become the first choice ablation modality for small HCC less than or equal to 3 centimeters. It works by a high frequency electrical current passed through an electrode, which causes tissue heating between 60 and 100 degrees Celsius, leading to coagulative necrosis. Before RFA, ethanol ablation was the standard percutaneous modality for small hepatic malignancies. So we typically reserve RFA for when patients are not surgical candidates or when they can receive resection or transplantation. Ideally, they're not going to have any extrahepatic disease or vascular invasion. And per the BCLC staging system, we typically reserve RFA for patients who are stage 0 or stage 8, and that means they have less than 3 tumors or 3 or less tumors which are 3 or less centimeters in size. People have done larger mass RFA, but typically 0 to 5 centimeters is typical. And you can do RFA on metastatic disease as well with pretty similar size criteria as we use for HCC. So outcomes for RFA. So in a prospective randomized trial comparing RFA and surgery for a single lesion less than or equal to 5 centimeters, they showed more or less identical overall survival at 1, 2, 3, and 4 years. And complications, as you would kind of think, would be more severe with surgery than with minimally invasive percutaneous approach. Another trial compared similar, but except it was a single tumor less than or equal to 5 centimeters or up to 3 tumors less than or equal to 3 centimeters. And they had no statistical significance in overall survival. So really, patient selection is going to be key to achieve good outcomes. As one would expect, tumor control is going to get worse as the size of the lesion goes up. And now, because RFA has been around for a relatively long period of time compared to other ablation modalities, we do have some long-term survival data at 5 years, 60%, and at 10 years, around 27%. So microwave is probably the second most common ablation modality used today. And this uses electromagnetic energy at 2 different wavelengths depending on the machine that you're using. And this leads to frictional heating, which can achieve temperatures greater than 100 degrees Celsius. The way we perform the procedure with CT or ultrasound guidance and the indications as to why we would do microwave are more or less the same as RFA. It really just kind of boils down to what machine you have available to you and what your preference is and how you were trained. There are newer microwave units that are a lot better than the original units, and that you can get larger ablation zones, more spherical ablation zones, and faster ablation with the newer units. So microwave started becoming more and more popular in the late 90s and early 2000s. And like I said, the newer units are better. And so since microwave started after RFA, and the newer units are even more recent than that, they don't have as good or as robust long-term data available for microwave. But RFA remains cheaper to use than than microwave, and therefore it's still the most common modality worldwide. But in a few studies, they have shown that overall survival with microwave for quite large tumors or multiple tumors up to 5 centimeters, they had overall survival of around 41 months. And 1 in 5 year survival rates are similar to RFA. And larger tumors, as again expected, are not going to have as good outcomes. So comparing the two, RFA relies a lot on electrical conductivity, which has a lot to do with your water content and the tissue being ablated. So while RFA has the ability to heat above 100 degrees, if you get to that point, you start dehydrating the tissue, which is going to lead to charring on the needle, increasing your impedance, which limits your ability to achieve a satisfactory ablation. Microwave is less prone to that problem. The RFA needles are typically monopolar, so you have to use grounding pads to complete this electrical circuit, and that is a potential site for burns, whereas microwave needles are bipolar, so that's not really a concern. Microwave has faster ablation compared to RFA, larger ablation zones, and you're less prone to heat sink. And what heat sink is if you have a tumor with blood flowing through it, the blood is at body temperature, and it's going to carry the heat away from your ablation zone, and so it limits your ability to achieve satisfactory ablation. So while all the ablation modalities are prone to it to some degree, RFA is probably the most prone to it. And microwave is less prone to be affected by or affect prostheses placed. Cryoablation is another ablation modality that we have access to, and as opposed to microwave and RFA where you're killing tumor by heating it, in cryoablation you're cooling the tumor with either liquid nitrogen or argon helium gas. The cell death mechanism is multifactorial, but eventually you're leading to hypoxia. And one of the advantages of cryoablation over microwave and RFA is that you can very precisely see the ice ball being formed. Here you can see it in a water bucket, and here is in a phantom. You can see very clearly the edge of your ablation zone. The kill zone is not necessarily going to be all the way out to the edge of this because it's going to be colder towards the center. It's usually within a few millimeters. But this is very helpful when you're doing an ablation near a critical structure that you want to make sure that you don't include within your ablation zone. You don't want to injure something nearby. So you can see how far your ice ball is formed under either ultrasound or CT, and so you can make sure that you avoid hitting that target. And then the indications and technical aspects of placing the needles are, again, similar to both microwave and RFA. So in a multi-center randomized controlled trial comparing RFA and cryoablation, they found that the overall survival and tumor-free survival were more or less identical between the two modalities for patients with these characteristics seen on the left. The local recurrence rate was slightly less with cryoablation than RFA, but that was not statistically significant. IRE, or irreversible electroporation, is one of the newer ablation modalities available to us. And this increases cell permeability by applying a voltage to the cell. And what they found is that if you apply a high enough voltage, that permeability, which can be irreversible. So you're creating these nanopores within the cell membrane, and if you're creating them fast enough, the cell is not going to be able to repair them fast enough, and so that's going to lead to apoptosis. IRE, one of the advantages is that it spares fibroconnective tissue, so bile duct and vessel integrity is generally spared, which is very useful when you're trying to ablate tumors in very sensitive areas. It's less prone to heat sink than any of the previously mentioned ablation modalities. And we usually do IRE when other ablation modalities are contraindicated, either because you think heat sink is going to be too much of a problem or because you're too close to a critical structure that you'd be worried about with any of the other ablation modalities. IRE has not been available or has not been around for that long, so we don't have very good long-term data for it. But for HCC, there's one study that, admittedly not a large number of patients, but they had a almost 12-month progression-free survival. There was no treatment mortality in that study. But one of the complications that bears mentioning is development of a cardiac arrhythmia. So you are introducing some kind of electrical current into the body. The closer you are to the heart, the more likely you're going to induce that. And so one of the contraindications to IRE is people who have a known cardiac arrhythmia. Since the development of the machine, they have combined a second machine that allows you to gate the delivery of the electrical pulses to the cardiac cycle. So this risk is significantly less than what it used to be, but it's still present. And here's an example of a tumor that was right at that confluence of the hepatic veins, which would be very difficult to get to from really any surgical or local regional method. So with IRE, they're able to get it to shrink down significantly at 2 months post-procedure. And you would expect that to continue to shrink down on continued follow-up imaging. Ethanol ablation was kind of the father of all the different ablation modalities. It's not used as much anymore in the United States. It's still fairly commonly used worldwide. But you stick a needle into the tumor and you inject pure alcohol into it, which kills the tumor. Right now in the US, it's mostly used for tumors that are very close to the heart that you'd be worried about injuring the myocardium. And there are newer needles that you can have these expandable tines so that you can get a larger zone of coverage than you could with just a single end hole needle. So moving on to transarterial therapies, I'm going to start with TACE, which is the current standard of care for multinodular HCC in people who have relatively preserved liver function. So going back to the BCLC staging system, These would be the intermediate stage patients or stage B patients, and it is considered a palliative treatment for BCLC, even though sometimes you can achieve complete response, but it's still technically a palliative procedure. Because you're placing a catheter in the artery proximal to the tumor, you're going to be able to get larger doses of chemotherapy to the tumor than you can with a systemic administration. But as a result of that, you're only treating the portion of the liver that's distal to your microcatheter, so you can have tumor elsewhere in the liver that you either know or don't know about that is not going to be helped by your treatment. But it can be repeated as needed as long as the patient has appropriate liver function. One of the problems with TACE is that there's so many variations in how it's done. Some of that is outlined in this chart over here, and that you have the conventional TACE where they mix chemotherapy with ethiodized oil, and then you follow it with an embolic agent. And then you have people who will just place a microcatheter, inject the chemotherapy directly into it, and take the microcatheter out at the end of it. And then there are people who will just inject beads alone to block the arteries as an embolization effect, but without any chemotherapy at all. And then you have the drug-eluting bead group where you have these beads that are soaked in chemotherapy for several hours. You inject the beads to block off the blood supply, and then slowly the chemotherapy leaches off the beads into the tumor over the next few days. So besides the variations in how you actually do the procedure in terms of what technique you're going to use, there's differences in catheter positioning. Some people will treat routinely the entire lobe at once, whereas some people will try to get the microcatheter a little bit further into the liver, and there's no standardization for that. And then the endpoint, do you go to near stasis if you're going to embolize at all, or do you just try to get to near stasis? So are you trying to completely cut off the blood supply, or are you just trying to prune the vessels a little bit? And then how often do you repeat? Some people do this every month as long as the patient can handle it, or do you do it once, see where you got, and then decide based off of that where to go next. Of the variations, the most common two are going to be your conventional TACE and your drug-eluting bead TACE. There's no clear survival benefit of one over the other. So again, it often comes down to just how you were trained and what you have available at your hospital. Drug-eluting bead TACE has been shown, though, to have a lower systemic drug exposure, reduced liver toxicity, and better tolerability compared with conventional TACE in several studies, although that is being somewhat refuted, or at least believed by some people. When not to do TACE, people who have poor liver function, which we say child PB8 or higher, are usually not good candidates, but I'm going to go a little bit more into that in a little bit. And people who have significantly reduced or completely thrombosed portal veins. Usually they're not going to do as well in general, but there's a higher incidence of complications after TACE. If you're able to get your microcatheter very far out, an example here, this is a proximal injection where you see the tumor lighting up like a light bulb, but you have a lot of normal liver as well with this injection. If you injected your chemotherapeutic beads from this point, you are going to get the tumor, but you're going to get a lot of relatively normal or healthy liver at the same time. But if you can get your microcatheter very far so that you're supplying almost only tumor and really very little normal liver at the same time, then you can be a little bit more aggressive. You can perform the procedure in patients who otherwise may be contraindicated. So outcomes, the original studies were done with conventional TACE where they compared TACE versus no therapy, which was really optimal management at the time. And they showed that there was a survival benefit whether there was or was not portal vein thrombosis, although the outcomes were significantly better if you did not have portal vein invasion. There were more recent trials comparing drug-eluting beads with doxorubicin compared with just bland embolization, and they showed that there was better complete response, fewer recurrences, and longer time to progression when you, with the drug-eluting beads as opposed to just bland embolization, but there was no survival benefit shown. So more recent studies have shown better 3-year survival rates and just overall survival rates in more recent studies that compared with the original studies. And while some of that was or is believed to be due to better technique and being able to get more distal as opposed to doing more proximal embolization, the vast majority of that improvement is actually thought to be due to better patient selection more so than anything else. And one important thing to remember in terms of patient selection is that I said in the beginning that we usually do this for BCLC stage B patients, and this is a very large heterogeneous group. So even within that group, you're going to have a very big difference in your outcomes depending on where along the spectrum they lie. And still worldwide, about half of TACE is done in BCLC stage C patients. So SORAFENIB, which was mentioned a little bit by Dr. Tan, is a tyrosine kinase inhibitor with some VEGF properties, and typically done where local regional therapy and surgery is contraindicated. And so when you're doing a TACE, you're blocking off the arterial supply to the tumor. And the body reacts to that by creating angiogenesis and trying to form new arterial supply to the tumor. So some people thought if you combine TACE with SORAFENIB, maybe you'll be able to achieve better results. And they did find in patients who are BCLC stage C that you do get a little bit of improved outcomes than with either therapy alone. And these are patients who would typically be getting SORAFENIB anyways. But in the SPACE trial for stage B patients, they didn't really see any benefit of doing so. So combining with ablation, one of the problems with ablation that we mentioned is the heat sink. So if you remove the arterial supply to the tumor, you may be able to get rid of a lot of that heat sink property, and you may be able to improve your effectiveness of your ablation. And there were 2 meta-analyses which showed improved survival, overall survival, and recurrent-free survival when RFA was combined with TACE, better than either RFA alone or TACE alone. The effect was really only noted in tumors that were greater than 3 centimeters, which makes sense because when the tumors are small, you'd expect RFA alone to be quite effective. And combination therapy for tumors greater than 3 centimeters in terms of overall survival was comparable with surgical resection in 2 studies, but the disease-free survival was similar or slightly less depending on which study you look at. So moving on to radioembolization or TARE or Y90 or SIRT, a lot of different names for it. These are very, very small microspheres which are loaded with yttrium-90, which is a pure beta emitter with a 2.6-day half-life and about 2.5 millimeter of tissue penetration. There's 2 commercially available products, which are SIRSpheres and THERASpheres. They have slightly different physical characteristics in terms of how many number of beads you're going to inject per any certain treatment and how much radiation you're going to get per bead. Around the world, around most parts of the world, both products are approved for most primary and secondary liver malignancies. But in the US, SIRSpheres is approved for metastatic colorectal cancer, whereas THERASpheres is approved for HCC. But even in the US, you can use either one off-label to treat any primary or secondary hepatic malignancy that you want. And it usually comes down to what you happen to have in your hospital and what you've been trained and what method you prefer. So for intermediate stage HCC, TACE remains the most common local regional therapy worldwide, but Y90 has been shown to be more tolerable, but there's no prospective head-to-head trial comparing the 2 directly. But in one retrospective review comparing very similar characteristics of patients in each arm, there was longer time to progression with Y90 and less complications. But again, overall survival was not statistically significant. And this has been shown in several studies since that, one of the first ones mentioned here. In advanced stage HCC, again, SORAFENIB is what we would typically do for these patients. But there are some large cohorts in phase 2 trials which show higher response rates and better survival with Y90 as opposed to SORAFENIB. And in at least one retrospective multi-center trial comparing the 2, the overall survival was better with Y90 than SORAFENIB. There is the ceramic trial, which is evaluating BCLC stage C patients, combination therapy versus SORAFENIB alone. We still don't have the final data on this trial, but the preliminary results show that while there was a larger amount of total adverse events and greater grade 3 or greater adverse events with the combination group, which you would expect because you're adding a therapy to it, the difference was not statistically significant. But in terms of its benefit, we're still waiting on the final results. Downstaging HCC towards transplantation or resectability is something that we try to do very frequently. And you can do that with really any of the previously mentioned modalities between ablation and transarterial therapy. But TACE is probably more commonly used for this purpose. But again, in a trial comparing Y90 versus TACE, and again, very closely matched groups of patients, the tumor size was very similar in both groups, and the partial response rate was better in the Y90 group. The downstaging from T3 to T2 was better in the Y90 group. The time to progression was not statistically different, but when they were designing the study, they decided that they were going to use the WHO or EASL criteria, which doesn't allow you to account for progression of disease in untreated areas like the contralateral lobe. But when they used a imaging response criteria that allows them to account for that, then the difference was statistically significant. And then these patients remained downstage for a longer period of time with Y90 than TACE. So there is some evidence out there, although it's not great evidence that is retrospective, but there is evidence out there that Y90 may be better at that than TACE. So Y90 is also used in other cancers, like I mentioned before, such as metastatic colorectal cancer. Usually this was done as salvage therapy, and even as salvage therapy after multiple lines of chemo, there was an advantage to doing Y90 at that time. And as you would expect, people who had significant volume of disease, poor response to Y90, or failed multiple lines of chemotherapy, they had the worst prognoses. But there are several phase 1 and phase 2 studies which showed that Y90 can be safely done in first, second, and third line with first, second, and third line chemotherapy. And here's an example of a tumor that is pretty much adjacent to and really touching the pericardium. And so it would be very difficult to get to for any ablation modality to really effectively treat this. And so they thought in this case the best thing to go with would be Y90. And so here you can see that after, unfortunately, they weren't able to completely eliminate the tumor, but there was a partial response in decreased size and decreased metabolic activity. So then, like Dr. Tay mentioned, there was a SIRT trial, which was a phase 3 multi-center trial for non-resectable liver-only or liver-dominant metastatic colorectal cancer. Patients had to have good performance status and ideally no prior chemotherapy. And they compared FOLFOX with or without bevacizumab versus FOLFOX with or without bevacizumab, but with the addition of Y90 performed at the first cycle. So the two groups were very closely matched. One difference is that the dose of oxaliplatin was less in the Y90 group, and then they would start the bevacizumab at the fourth cycle. There was a higher proportion of extrahepatic disease than was being anticipated when they were designing and enrolling patients into the study. But what they found was in the liver, there was significantly improved progression-free survival and response rates with the Y90 group. But as you would expect, in patients who had extrahepatic disease, the difference wasn't statistically significant because the Y90 is not really going to help those areas of disease. Overall survival, we're still waiting on to the completion of two other trials, the Foxfire and Foxfire Global trials, which include a very similar cohort of patients. And so they wanted to have the largest number of patients they could to pull together to try to best detect if there's an overall survival benefit. And we're expecting those results within the next few months. Y90 is also performed, or local regional therapy also performed for neuroendocrine tumor mets. And ideally, you go to surgical resection whenever possible, but unfortunately, it's only possible in less than 10%. So Y90 has been shown to decrease tumor markers, improve your symptoms, and improve your overall survival. And the big range in overall survival in these studies is owed to the proportion of pancreatic neuroendocrine tumor you have. So the more pancreatic neuroendocrine tumor you have in that group, the less your overall survival is going to be versus GI neuroendocrine tumor. There is no randomized controlled trial which shows which modality is best between bland embolization, chemoembolization, or Y90. There is a trend nationwide to go towards Y90 as the first line because it is the best tolerated of the group, but it is by far the most expensive. So worldwide, it's not used as often in that regard. According to the 2016 NCCN guidelines, though, you would usually initiate local regional therapy for neuroendocrine mets whenever you document tumor progression. But there is some anecdotal evidence which suggests that if you have liver dominant and very significant liver disease in terms of your metastatic tumor burden, then you can go ahead and do it from the get-go instead of waiting for tumor progression. Y90 has also been done in other malignancies, all listed here between cholangio, carcinoma, breast cancer, pancreatic, uveal melanoma, RCC, and lung cancer. These have not been studied as extensively as the HCC, colon cancer, and neuroendocrine, but they have found benefits in all of them when appropriate patient selection was performed. So moving on to transvenous therapy. Portal vein embolization is something that we can do for people before they have hepatic resection if we believe that their liver remnant is not going to be large enough for them to survive off of, and Dr. Tan alluded to this a little bit in his talk. So we call that the future liver remnant, and by blocking off the blood supply to, let's say, the right lobe of the liver from the portal vein, you're redirecting portal vein flow to the left lobe, which will lead to hypertrophy and hyperplasia. So if your future liver remnant is too small, this has been shown to be associated with a complicated postoperative course. And so by performing portal vein embolization, they have shown a decrease in the postoperative morbidity and increased the number of patients eligible for a curative intent resection. A 200 cc remnant liver in somebody who weighs 100 pounds is going to be very different from a 200 cc liver in somebody who weighs, let's say, 300 pounds. So we often go with a standardized future liver remnant to better account for different patient sizes. So here's an example of a portal vein embolization. You have your pre-CT, which shows a very small left lobe of the liver, and the right side of the liver is the part that has the tumor. This is a portal venogram, which shows the portal vein architecture, the right side of the liver and then the left side on this side. They selected the right side with a catheter, and then they embolized it. And this is after embolization. You see the right side of the liver really has no more portal vein flow at all, and all the portal vein flow is going to the left side of the liver. They repeated a CAT scan after the procedure, which shows difference in attenuation between the left side of the liver and the right side of the liver. That's due to perfusion changes. And then after resection, you can see that the left side of the liver, now the future liver remnant, is much larger than it was before, and the patient was then eligible for resection. So when do we do portal vein embolization? If the future liver remnant is going to be less than 20% in somebody who has a normal liver, then you would do it. In somebody who has steatosis or has had hepatotoxic chemotherapy, if their SFLR is less than 30%, you do portal vein embolization. And in cirrhosis, less than 40%, or sometimes, like Dr. Tan said, even 50%, you would think of doing portal vein embolization. If somebody has extensive ipsilateral tumor thrombus, you don't want to do portal vein embolization. They're essentially naturally portal vein embolizing themselves. And if somebody has portal hypertension, then it's probably not a good idea to do it. One, there may not be a candidate for hepatectomy, but also your risk of complications and non-target embolization is going to be significantly higher. So outcomes, the healthier your liver is, the faster your liver is going to regenerate, and which may take anywhere from 2 to 4 weeks. And the more diseased your liver is, it may take 4+ weeks. In the study, that retrospective study, 54 patients, 21 of which received portal vein embolization, there were no perioperative deaths in the portal vein embolization group, whereas there were 6 perioperative deaths in the group that did not have portal vein embolization. When you excluded the patients who unfortunately had passed away, the overall disease-free survival was similar in both groups. When you cut off the portal vein blood supply to the portion of liver that has tumor, you're increasing their arterial supply to that side, and that may lead to increase in their progression of their tumor. So what they've done is they tried to combine TACE with portal vein embolization, doing the portal vein embolization a month after, and they had not only an increased hyperplasia of the SFLR, but improved overall survival and recurrent-free survival. And there's future research being done to try to optimize the best method to go for and to better patient selection. People have done radiation lobectomy, where you do a lobar Y90 with a relatively higher dose than you would typically go with just standard Y90. And so you can treat tumor and induce hyperplasia of the contralateral side in a single treatment. And this has been done successfully and led to people being resectable or transplantable. The comparison of the two, though, is that portal vein, you're going to get more rapid and greater degree of hypertrophy, but you're going to, you may have to go with a TACE, so it's going to prolong your treatment timing. And then with the Y90, you're going to be able to do it all in one session. But the concern is if somebody gets a portal vein embolization and then they don't hypertrophy enough to get surgical resection, you've now embolized somebody's portal vein, you've eliminated surgery as an option for them, you may have eliminated several modalities for them to be able to continue their therapy, and so you've kind of put them in a tough spot. And then lastly is percutaneous hepatic perfusion. It's only available in a few sites because it requires very specific machines and equipment. But you place a microcatheter just like you would for any other transarterial therapy. You inject high doses of chemotherapy into the hepatic arterial supply, but instead of it going into the hepatic veins and then systemically, it's caught by a catheter that's placed through the groin into the IVC with balloons above and below. And the chemotherapy is then filtered out of the body through this special system, and then the blood is put back into cannula through the IJ, which allows you to get very high doses of chemotherapy with very low systemic absorption. This requires anesthesia and perfusion support. It's primarily done for ocular melanoma metastases. These patients have very dismal prognosis, but it has been done in very few numbers in patients with other diseases as well. So in conclusion, there's a lot of things that we can do from a minimally invasive standpoint. Combining procedures where appropriate may get you better results. Patient selection is very key to that, and we need, as you can tell, a lot more research to better stratify which patients should receive what therapy. And some patients may, you may be able to get cure with certain procedures such as RFA or microwave ablation, but if patients have poor hepatic function, you got to be a little bit more careful, and really all decisions should be made in a multidisciplinary tumor board setting. Thank you.